All right. Yeah, we're good to go. Okay. All right. So my name is Senthil Sukumar. I'm currently a hematologist at Baylor College of Medicine, not too far away in Houston, Texas. So just 4 hours away for some of you. I also trained at Ohio State with Spiro Catalan for my fellowship. And so, you know, there's some familiar faces from both Ohio and Houston here. So that's nice to see. But today we'll be talking about stroke, pregnancy, and cognitive hurdles in TTP. These are, you know, again, we want this to be collaborative, and so you guys can kind of interject at any point. There's a lot of slides. We don't have to get through all of them. But just in the fairness of kind of talking about both sort of things, because there's sort of two major topics in terms of the neurological stuff and then the pregnancy stuff, I'm going to start off by talking about cognitive issues and stroke, but then at about, let me see what time we're at. So maybe about 10:45 or so, I'm going to switch track to pregnancy just so that we can kind of give roughly 20 minutes to both, you know, aspects. Just because I know people have already kind of come up with, I think, some questions about both. So we'll just go ahead and get going. So we're just going to talk a little bit about just TTP in general. Then we'll talk about the neurological issues. We'll talk about things that we do in pregnancy and considerations we have, and then the next steps. So you guys have seen this, and you probably will see this a few more times this weekend, but we don't have to go over each, you know, detail, but suffice to say that the ADAMTS13 enzyme is the root of the issue here. It's the main protein that's supposed to regulate or chop up that von Willebrand factor into the normal or physiologic sizes so that you don't have problems. But what happens in immune-mediated TTP is you have antibodies, those little green Y-shaped things that will block or sometimes clear the ADAMTS13. And when it's not there, those strings of von Willebrand are just way too big. And they can bind up the platelets. That's what causes end organ damage. That's what causes the fragmentation of the blood cells that we see when we look at the blood film under the microscope. And this causes all of the root issues of TTP. And so there's the microthrombi formation, which are the small, tiny blood clots in those capillaries and arterioles, and that's what causes the end organ damage that you get when you're in an acute episode. I just present this slide to show you we've come a long way in the last 30 years, but also to highlight really in the beginning. So this was first described actually 100 years ago now by Eli Moskowitz. It was the first report that was published in a 16-year-old girl. At the time, when you developed TTP, the mortality rate was greater than 90%. They didn't know what caused it. They didn't know what to do about it. But in the 90s, so 70 years roughly goes by, and then they realize plasma exchange seems to work in these folks, and the mortality rate shifts. Instead of 90% of people dying from this, we have about 90+% of people living. And since then, it's been incremental, but we've improved. Right now, less than 5% of patients pass away from an acute TTP episode. That's not to say it doesn't ever happen, and our goal is for it to never happen. But we've come quite a long way. And with that long way, we've shifted a little bit from worrying so much about keeping people alive during that acute episode, because we're doing a much better job of that now. And we're setting our sights on what happens with our folks after they recover and they're doing well and we're seeing them in clinic. Because really prior to this point, we just didn't have folks that were alive 10, 20, 30 years after their initial episode. And so we're beginning to describe and see things that we honestly maybe didn't expect. So let's talk a little bit about the neurologic sequelae of TTP in general. So in the acute episode, they teach us in medical school about a pentad or a classical, you know, set of findings, 5 findings in particular that they want us to associate with TTP. So if someone shows up to the hospital and you're the hematology on call, and they've got fever, a low platelet count, a low blood count, any neurological issues, so confusion, things of that nature, or kidney issues, you need to be thinking about TTP. But the actual pentad, all 5 of these things coming at once, is actually really rare. Less than 5% of people will have all 5 of them together. Almost all people are going to have the blood findings, so low blood count, low platelet count. And the neurological findings are also very common. So that's one of our biggest differentiating factors when we're seeing this constellation of symptoms. If there's more neurological involvement, we naturally think more about TTP as opposed to the other TMAs, which you guys heard about in the prior talk. So about 60% of folks will have neurological symptoms at their initial presentation or relapse presentations. This can vary anything from headache all the way to a coma. And, so I know some of you in this room can relate to when you first had your episode, you may have been somewhere along this spectrum of severity. The way that we typically start by looking at these things during the acute episode is with imaging. So either a CT scan or an MRI while you're in the hospital, but often even if you're having some of these symptoms, there may not be anything that shows up on the scan. They may just see, kind of non-specific things like edema or swelling in certain areas of the brain, or what they sort of just call microvascular injury. They kind of see some stuff, but there's not like an obvious stroke event or anything like that. They can happen though. So strokes and bleedings are less common, but they do exist. But now let's switch gears a little bit and talk about in remission. And this is sort of where we've had a lot of our more recent findings described and our understanding of how things look while you're, doing well and your platelet counts are normal. So there's various types of neurological sequelae or consequences from TTP, and that can be neurocognitive, neuropsychological, neurovascular, and also impacting quality of life. I'll go into detail about these things in a second. So neurocognitive symptoms are very common in folks who have had at least one episode of immune-mediated TTP. These are mostly things dealing with memory, attention, focus, some of the things that you guys may be feeling. And these are the things that we hear in clinic all the time from not every single patient, but a lot of our patients, and more than we might expect for something that was previously thought to be just a hospital disease or an acute issue. So people say they keep forgetting, what very short-term things, what they've done, what they want to do. Some folks make a little bit more mistakes at work, and this can be bothersome. Other people who are still, getting their education or even other tasks, they find difficulty focusing, right? And this is probably the biggest one that I hear, but the concept or just the idea of brain fog. It's a bit nebulous, but I think a lot of people kind of get what we mean when we say that. It's just about the clarity of thought or the ability to think clearly when you need to. So this is also very subtle, and that's what we're finding out. This is not dementia, and this is not actual intellectual impairment. It can be frank neurocognitive impairment, but it's not always. So in some of our other registry studies, in the Oklahoma registry, they showed that there's no dementia when we actually test this on the mini mental state exam, which is a tool that we use in clinic to look for this. And people are still independent. They're doing, their daily jobs, they're doing their daily activities, but they do see subtle deficits in certain things like attention, manual dexterity with their fingers, rapid language generation, and rote memorization. So some of these issues that we were talking about. And in a collaboration between our colleagues over in the UK and Ohio State, there's also some impairment in tests on visual learning and memory in some of our patients. We're going to tie this in a little bit with neurovascular sequelae. And what we mean by this are potential problems with the blood vessels in the brain. And really what we're talking about here is going to be stroke or stroke-like events. So there's a concept known as silent cerebral infarctions, okay? Basically, what this means is these are stroke events that can occur without any symptoms present at the time that they occur, okay? And these are diagnosed with a brain MRI, and you could be functioning totally normally and not have any clinically apparent issues. But a recent study done in the Johns Hopkins registry actually found that in 50% of the patients that they checked, around 30 to 50 folks, that they did in fact have silent cerebral infarctions. Now, this actually happens in the general population too, so at a higher level than even you might expect. So almost 17% of healthy people that without TTP that they checked also had these findings. But you can clearly see that in the folks with TTP, it's a little bit higher than even that general population level. The other finding was that these stroke-like events were also correlated or associated with major cognitive impairment on a scale. So before we would identify folks having these kind of subtle cognitive issues or, the brain fog, the memory things, and we didn't really have anything that might tie into it. And while this isn't definitive just based on this one study, this may explain a little bit of what we're seeing in terms of these cognitive issues. I also want to be clear though, Not every single patient with cognitive symptoms necessarily had any stroke at all. So even though we're presenting this data like this, I don't want you to think that this is inevitable or things like that, but it could be something that's related or explains it. Things that may increase the risk of stroke while you're even in remission, so not even during an acute episode, but we've now come to realize that having a diagnosis of TTP is starting to look a lot like other conditions where you may be at risk for cardiovascular disease. So what are those other conditions, for example? Diabetes is probably one of the most common ones. So in the medical field, we consider diabetes as a cardiovascular disease equivalent. Okay, so those patients are screened way more for things like heart attacks and strokes. They're put on medicines at a sooner age or at sooner time points than you might traditionally do. We're starting to understand that TTP or having a history of TTP may also be a cardiovascular disease equivalent. So we may need to be a lot more hawkish about your blood pressure, your cholesterol, all of these other factors. And this is a big deal because most of our patients are younger folks, younger women especially. These are not the typical, in the United States, we think of the obese 60-year-old man who gets a heart attack. That's the prototype of that kind of syndrome in that scenario. But when we're seeing these issues in a patient population that you don't normally think about, we have to be aware that this is occurring and so that we can try to help prevent those problems. And these events may also be related to the ADAM-TS13 activity during remission. So what the study at Hopkins found is that if your ADAM-TS13 activity was on the lower end, you may be more likely to have these events occur. There's a lot of different explanations for this. We talked a little bit about traditional risk factors like high blood pressure, being overweight. Also, many of our patients, as you guys may know, have other autoimmune diseases as well. And so these events are also increased in those other autoimmune conditions. This, however, gives us earlier time points at which we can potentially intervene and prevent these issues from happening. So if you kind of think about it as the bottom of the triangle being sort of the earliest stage, and then the middle leading up to actually overtly having a big stroke with symptoms, we're slowly making our way down that triangle to a point where hopefully we catch everybody at the bottom, where we can help prevent these episodes in the first place. In terms of the neuropsychological effects, this is really more a nod to the mental health of our patients. And so in all of our registries, we're seeing that the screenings for depression and post-traumatic stress syndrome, which is really just any kind of event that can be traumatic that you experience or even that you witness. And certainly I think being admitted for plasma exchange and the rest of the acute TTP stay absolutely qualifies for that type of an event. And rates of depression and PTSD were also associated with unemployment, which does affect some of our patients. The depression and PTSD is also associated with reductions in quality of life. So there are several ways in which this is measured, usually many surveys and other things, but we have found that when our patients are experiencing depression and PTSD, this can significantly impact that perception of quality of life and make some real differences there. So what are the next steps you may ask about, strokes in general? First, we have to acknowledge that this is even a problem and then validate the patient's experience. 20 or 30 years ago, when people would talk about brain fog and other things, we'll be like, you're out of the hospital now, everything's okay. But I think we're at a point where we've really characterized and understand that this is a real phenomenon. And so I think the first thing is just listening to our patients. We can also provide currently available treatment and support. So several patients who had on those earlier studies with the depression, the PTSD, and the decreased quality of life found that having either medication to treat those things or just discussions with therapists and counselor did actually improve their symptoms. And this is probably a tool that we maybe not reaching to often enough. We also need to identify potential drivers of these silent cerebral infarctions earlier, and perhaps we should be ordering MRIs at a sooner time point. That study that was done at Johns Hopkins is now going to be done at more sites throughout the USTMA. And so once we have data from a larger sample of patients from a larger geographical area, these are how we can, research is a slow process inherently, but these are how we can implement these kind of changes over long-term follow-up And in the next, 5 years or so, there may be a guideline recommendation perhaps that we should be doing a screening MRI at various points throughout your journey. We're not there yet, but that's a thought. And then continuing to conduct this research, I think, is also a next step. So these are some of the open questions that we're still trying to understand better and that we're trying to address through the USTMA. But really the core of this whole thing is how can we prevent these issues before they occur? Because it's great that we're identifying them, but we can't pat ourselves on the back and sort of say, that's all good. We should try to prevent these things before they even happen. So that's what I had for stroke, and we're actually a couple minutes ahead of time. But any questions on the neurological side of things before we shift gears a little bit and go to pregnancy?
I guess it's a lack of knowledge about issues that don't understand when you come to the. I used to eloquent speeches. I don't do it anymore because I can be in the middle of it. I can have my notes say, and it's getting worse.
Yeah.
She's going to tell you the word. Then we'll see if you remember. And then she gives you the word, and then he talks to you, and then said, you remember the word. That doesn't stop,
Yeah.
That was her test. But, if I go further. So I've been begging and begging. What do I have to say? Not to understand. I am frustrated.
Yeah.
Very frustrated.
I think this can be a real challenge because, unless our multidisciplinary colleagues, because I'm not a neurologist, right? You don't want me, anywhere near that stuff. But we, at each of these centers, hopefully that your hematologist is able to find providers who see this data and can help buy into it and have a better understanding of it so that they know how to test more properly. In similar situations in some of my own patients to what you described, I've actually found a partner in Houston at Baylor College of Medicine who is we have specific neuropsych testing. It's quite extensive. It's like a 6-hour day or so, and you're sort of put through, the ringer in terms of a lot of tests that seem kind of, silly to do, but and repetitive at times. But this is really helpful for patients who have progressive cognitive symptoms or issues like you're describing, because it can help us in a more objective manner quantify with validated testing instruments exactly what the deficits are changing, year to year. But then additionally, they have specific, they're actually not physicians, they're PhDs, but they have specific coping strategies on how to be successful at overcoming some of those deficits. And in the absence of being able to prevent these problems before they occur, that's about as good as we can do at managing and mitigating them as we're noticing differences. So it's about, I think, persistence and then trying to find those allies within your care network. And your physician can hopefully help you with that. Right? Exactly. There you go. Yeah, yeah. No one in the room's crazy. Yeah, I'll say that. Yeah, I think.
You talked about doing MRI for treatment. What would you see in the MRI? When you look?
So specifically regarding doing the MRIs more frequently or earlier, that's what this bigger study is hopefully going to help us answer and test. But essentially it's looking for those silent cerebral infarctions. So those are basically like small stroke events that do happen that don't have any manifestation otherwise, aside from us just doing that imaging. So that would be the goal of that particular intervention, but it also might make us be more aggressive if you start seeing that in other ways. For example, do we need to make sure the ADAM-TS routine activity is even higher than it is? So.
If you didn't have a stroke, is the cognitive impairment from the TTP episode itself, or does the medication, the treatment that you have, contribute to that?
This is a very fantastic question. So essentially, what is the cognitive impairment from in the absence of any overt strokes? I think the answer to your question is, number one, we don't exactly know. And number two, likely all of the above. So there's probably some multifactorial combination of the acute injury that happens when you first have the episode with all of the different treatment that you receive for that episode, And then not to mention if there might be any ongoing issues happening if you have a persistently lower ADAMTS13 level, for example. So the truth probably lies somewhere in that Venn diagram of things, but we're not quite there yet where we can pinpoint and say exactly what it is.
Have steroids, I mean, actually, steroids long term can have effect on health.
Mhm.
So saying that that's probably what I'm experiencing. Or maybe it's adrenal function.
Yeah, it depends exactly how far out you are from, the steroids and how high and how long they were on and things like that. But yeah, it's probably some of all of the above, for sure. I don't know whose hand up was first over here. I saw some. Okay, we'll just start here.
Wow. My general question on just this. It seems like more doctors are quicker to respond when they start under their care in the hospital. First of all, I'm hearing most people saying that when they go into general checkups and they're saying it makes them worse off. And I don't understand why. It seems like if the patient is there, you ought to know it's going to have this issue. It's standing in front of you. Why is it being pushed off? Why is it being pushed further? Because I know off topic, our son you keep and certain things that he was telling us, and parents, we look at certain things that we didn't understand because we didn't know what it was. But when we took him to the doctor, he wasn't under their care. While he was in the hospital, he said that he jumped. But when he was home up under our care, he looked at himself with the check and they said, play. They got the ball, we didn't play. So I was saying that's something that they have to do, just be nasty and get what they need.
Well, hopefully not. I mean, hopefully not. I think, that's part of what hopefully the USTMA can help out with is increasing provider education and awareness. I mean, I think we do realize that not everybody can be seen at one of these, TTP centers of excellence where they have a lot more of this knowledge about the background, on the long-term effects and things like that. To answer your first question, I suspect that's occurring because when you're in the hospital, it's a lot more of an acute issue. It's like life or death. So you got to address any little thing here and now. And then in the clinic, when things are stable and fine, they're like, oh yeah, we'll see if it's okay in 3 months. And then, you kind of keep moving on. I think the root of your question though, is just enhancing provider awareness so that they realize these are real issues and issues that we can and should be addressing. Yeah. And then I'll get you next.
How do you determine the difference between a stroke and a stroke? Because, the first time I had my episode, I lost complete function on the face and the whole side of my body. I was employed, I was in the facility we had there. And, I slowly regained, all function. And they told me I was high. That's what you do in the military.
Okay. Yeah.
Then, so they took me back to my back. And then going back, the opposite side of my body. So,
That's not good. And when he was able to speak, he will answer nonsense for.
Yeah.
and so, when I go to right, I tell them I have a struggle, and they did. So, I'm just trying to figure out.
Yeah, I mean, and so medically speaking, essentially I think it sounds like you're describing in your situation, the difference there is a stroke is an irreversible, brain damage essentially due to loss of circulation through some mechanism in this context that we can see on an imaging study, whereas the term is transient ischemic attack, or TIA, is something that happens but then resolves, and then there's usually not any imaging evidence of it. And so a TIA is on the way to a stroke, if you will. It just didn't actually knock out a part of the brain, and that's why you have the function back that from the symptoms that you're experiencing. So that's the difference, just from a purely sort of medical standpoint. But we treat them with roughly equal severity in the context of a TTP, episode, for sure. Yeah. Yeah, the medical terms of TIA instead of a stroke. That's right.
I've been parts of those folks use studies and stuff that we've been doing. So I'm just curious, where does that go from there? So I know, like to your point earlier, like we start feeling changes, platelets are lower, but not low enough. Like, does that drive a change to like that less than 20 low platelet thing before you get treatment? Is that where we're pushing this towards?
Yeah, so I think that we need to understand a little bit better how much and if having the lower ADAMTS13 activity during remission plays a role. Even though they see that association, it's not clear that it's the cause of these problems. However, if through more research and things like that, we determine that that is something we should be targeting, maybe that 20% threshold will go higher, right? And where that higher level is, I couldn't tell you right now, but that's a potential area of improvement that we have in terms of preventing these things for sure. So looking at the time, I'm going to switch to pregnancy. So keep your questions, and then we find us later, or you can send us an email. But just briefly, so healthcare maintenance in women with TTP. This slide just basically is what your primary care doctor should be doing. Just because you have TTP doesn't mean you should be ignoring all of these other things. So just your regular cancer screening, regular vaccinations. And just a brief word on vaccinations. There's actually no association between vaccines and TTP relapse, particularly if your ADAMTS13 activity is good at the time of vaccination. So, and that we've studied extensively, at least in the US. So pregnancy can be the initial trigger for various TMA problems, and sort of they're listed here in the first column. And TTP typically occurs in the second or third trimester or just shortly after delivery. It can occur, though, in the first trimester as well. It's just less likely, but it can happen. And in contrast to some of these other TMAs, delivery does not necessarily make it go away. And the reason that I say that, or that I want to highlight that, is because for some of the typical things seen in pregnancy, like preeclampsia or HELP syndrome, which is another type of issue that can occur during pregnancy, delivery is actually the method that the OBGYN and maternal fetal medicine doctors will use to treat it, because the issues resolve afterwards. However, with TTP, that's not necessarily the case, and something that everyone should be aware of. So the reason that this is such a big topic is because almost half of our patients are women of childbearing age. And so we do need to understand what to do about pregnancy and how to manage it, whether the initial episode happens or a TTP patient wants to become pregnant in the future. So pregnancy-associated immune TTP accounts for 12 to 25% of all cases, so 1 out of 8 or 1 in 4, depending on the cohort you're looking at. And we all know that there's that window where your ADAMTS13 activity is a little bit lower. Pregnancy can serve as that additional trigger to kind of kick you into the full clinical syndrome, okay? The clinical course of TTP during pregnancy is similar to if you're not pregnant, although there's just, baby or fetus involved. There may be more cardiac manifestations, so issues with the heart. And patients who have had pregnancy and TTP also have a higher risk for preeclampsia during their subsequent pregnancies as well. The good news is that the response to treatment is similar to those who don't have, who are not pregnant. So this is just taken out of the algorithm from some of our guidance documentation about how a provider will initially assess a diagnosis of potential TTP during pregnancy. But it's a little bit more complicated because there's other TMAs that can occur during the pregnancy as well. So it's just something that providers need to be aware of and thinking about. Now, the acute treatment for TTP during pregnancy is very similar to that when not, with some exceptions though. So prednisone is relatively safe in pregnancy. It does cross the placenta, and it can increase the risk of certain things like hypertension or gestational diabetes. That's diabetes when you're pregnant. But there's not really many fetal risks when used in the short term. And, this is something we would definitely do in conjunction with your OBGYN. Plasma exchange is okay. Rituximab technically lacks strong safety data in pregnancy. However, the use is becoming increasingly accepted in certain situations, and it's already being used in pregnancy and other autoimmune conditions, but that's still a discussion that you'd have to have on an individual basis with you, your hematologist, and your OBGYN. As of now, caplacizumab is not used or recommended in pregnancy, but however, it could be okay after delivery. So how do we manage subsequent pregnancies? And this is an issue that I know many of our women face. And each situation is unique. And so there's not just a one size fits all here, because it really depends on your clinical course and how things progress in your situation. But I will say, on a general level, having had a diagnosis of TTP or an episode of TTP in the past, even if it was pregnancy related, is not a complete contraindication to a future pregnancy. And so here's some proposed guidance, which I'll kind of dissect a little bit more. But essentially, it would be enhanced monitoring of the ADAMTS13 activity and hopefully improving that activity to greater than 20% while you're still TTC or trying to conceive. And so doing this in a more planned and intentional fashion would be sort of the best approach. So a prior history of TTP is associated with a substantial risk of relapse during pregnancy. And like I mentioned before, this can occur at any trimester, but it's more common in the second and third. And there's also a higher risk of some other complications like preeclampsia that you'd have to watch out for. And like we were discussing, the close monitoring of the ADAMTS13 activity and managing if it goes low is really imperative. So how do we manage or prevent ADAMTS13 relapse during pregnancy? So let's just say before you got pregnant, you received rituximab or something else, and your activity levels, well above 20%, you get pregnant, and now during these close monitoring, the routine checks that we're talking about, the activity level starts to drop or even goes below 20%. Some of the agents that we may use in this situation include azathioprine and cyclosporin. Now, we wouldn't want to use any agent if we could get away with it in pregnancy at all, but we're not just going to sit there and let you be at a low ADAMTS13 activity necessarily, depending on your history again, especially if you've had other pregnancy-associated episodes. So these are agents that have been used in other conditions and in other situations and that do have some side effects, but have shown enough safety profile that we feel comfortable to use them in a pregnant patient, and they can and do work well. And I know there's a few of you in this room actually that we've treated in a similar fashion and carried through successfully. I also mentioned rituximab in that kind of earlier scenario. This is a patient who may have already seen it prior to becoming pregnant very recently. So, however, in an increasing fashion, this is being used in pregnancy. It does cross through the placenta, and so you do have to watch baby a little bit more closely as they could be at higher risk for infections and things afterwards. However, it is generally safer than we once thought it was. So in patients trying to conceive, what we typically recommend is regularly monitoring the ADAMTS13 activity. And we feel that it is safer to become pregnant with a normal activity level than if you're starting out at a low level. And then if the ADAMTS13 activity is deficient, we would consider preemptive therapy with some kind of an immunosuppressant to kind of get you up before you become pregnant. So that's actually the references, and then we'll take any additional questions. I forget exactly how much time we have, but we'll keep going until they kick us out.
Hi, we have a question from someone at home.
Oh yeah.
Could a significant drop in ADAMTS13 activity cause depression and/or fatigue?
Yes, it can. Yeah. So the question is, can ADAMTS13 drop cause depression, fatigue, or other issues, headaches? Yes, it can. I think I saw you first.
If you already had a stroke prior to TTP or seizures prior, are you more susceptible to them?
Yes, because any history of having a stroke is also a predictor of having a subsequent stroke. So it would just be kind of like it'd be like having high blood pressure and cholesterol and diabetes. All these things will incrementally increase your risk. Yeah.
On the slides earlier, you talked about the pregnancy related, like what happened to the is it one still one?
Yes.
What's the study size
Yeah. It was quite small. I think it was like 50 or 70, something like that. And it was for a different condition. It wasn't for TTP necessarily. And actually on that slide, I should mention a lot of the side effects and things that you see or pregnancy outcomes that you see with some of these agents are also related to the disease which those agents are being used to treat in the first place. So that's something we also have to keep in mind. Yeah, they have to be reported as associated with the medicine, but the disease itself that they were treating for can also cause some of those issues for sure.
So sometimes there's, pregnancy associated with trauma, and also with pregnancy. I think there could be an association there even outside. But the increase in buffets, associated.
Yeah, that's a great question. I'm not 100% sure about the answer to that. I think that nobody understands the mechanism of brain fog. There's so many different, like, pregnancy, you see this when people are on chemotherapy, they call it chemo brain, for example. I think there are many different states or things that can kind of cause these similar phenomenon, but we're not exactly sure that it could be. Yeah.
I was wondering, what's the ratio of women to men with TTP?
Yeah, that's a good question. So it does predominantly affect women. And so they're the vast majority of our patients for sure. Yeah.
I know you mentioned diabetes. Being, high risk. What about cancer? Are you a high risk in the general population?
You mean cancer and leukemia as a risk for like stroke or heart attack? Or sorry. Oh, yeah, I see. So as far as I'm aware, no, I don't believe that we've seen that or shown that. Yeah. Yeah. So that's a good question. So the question was, with chronic immunosuppression therapy that, can and does have an increased risk of certain cancers. I think that increased risk is seen in many studies of, patients like with organ transplants, for example. And so we're talking about years and years and years of being consistently on, some of these medications, in some cases decades. And so generally speaking, even for discrete period of time of like, a few years here and there, while it's theoretically a risk, I think most of our patients aren't on it consistently and long enough for this to be a significant concern, but it's a non-zero risk. I know that's a bit of a non-answer, but yeah.
Question from someone at home. How frequently should patients be tested for platelets and ADAM-TS13 in remission?
That's a great question. So just generally, I'm going to interpret that. So our practice, at most of our USTMA sites, again, this depends exactly how long you've been out of your, initial episode. We'll typically follow our patients every 3 to 6 months for at least the first few years or so. And then, it kind of just depends on your course from there.
There's also colored women.
Yeah.
Is there a study?
So that's a great question. And I think that there's a lot of different reasons to that. I think, we'd be remiss if we didn't kind of comment on, in the United States, there is a history of systemic racism, which likely contributes to the increased rate of autoimmune diseases that we see in Black women in this country. Because they've shown that there's actually biochemical responses to chronic stress. Okay. And these things increase autoimmunity in general. And so while that's not definitive, it likely plays a large role in the reason that we see those disparities, specifically really within I mean, it can be anywhere, but we just have a more heterogeneous population than most other countries do.
Where so is that then the stroke
prior to moving those? Because I was getting silent migraines and some words.
Yeah, so what you're describing is probably like that neurological issues that can occur during or immediately preceding the acute episode. If it didn't cause a long-lasting issue, then it's probably in that TIA or transient ischemic attack category. But yeah, definitely related to the disease. But I saw, yeah.
I was gonna ask, kind of similar to the operational trauma stuff, but is anyone looking at if there's any connection to adverse childhood experiences, ACEs impacting or intersecting with TTP? Or coming out TTP?
That's a fantastic question, and actually something that maybe we can connect on a little bit more. I think that would be interesting to study, and I think it'd be great to study. We are looking at socioeconomic disadvantage and things like that throughout some of our USTMA sites. There's a marker called area deprivation index, but essentially using people's addresses, we can kind of get government level data about like the in a very small, like even smaller than zip code level of just what's the average income, education level, access to public transport, access to the nearest hospital, that kind of thing. And we are seeing some of these complications potentially mirror along those lines. So yeah, people are, we're starting to engage more with this type of analysis and thinking for sure. I did my training at OSU. I'm currently at Baylor in Houston.
University of Science Center.
Oh, yeah.
We do a lot of training in the syndrome challenges.
Okay, great.
We do a lot of ACEs.
Yes, yes. I can't, I don't know which one of you, but yeah, you go first.
Starting hypertension, post-gestational.
I mean, I want to say yes. I think that can happen for sure. Just medically, I don't know if it's necessarily related to TTP, but it likely is because our patients also have increased rates of hypertension and obesity and other issues compared when we compare to the general population. So certainly, yeah.
Is the clinical data that shows that stress is a trigger? Or is it that if you are stressed, your immune system is compromised, and that is the reason why you can have the TTP episode?
Yeah, so that's a good question, and the root of that question, I think, is in how you define stress necessarily, which can be kind of complicated from like a medical research, situation. What I can say is not necessarily in TTP specifically, but there is a lot of research showing that chronic stress, again, that's defined in a few different ways and by a few different mechanisms, does induce biochemical immune profile changes in people over time. And that certainly probably plays a role. Yeah.
We know that pregnancies have immunodownregulator. Normally, we have, pregnancy and
Yeah.
and when the female is pregnant, obviously it gets better. And in this case, they do develop TTP, it's an autoimmune upregulator.
Yeah.
So my question to you is how that this conflict happens on the pregnancy, or if it's related to any type of APO disease, I mean, mother having a different type of blood, with the fetus having a different type of blood. Or,
yeah. So that's a good question as to, how and why pregnancy may trigger, right, TTP episodes. So the only correction or slight correction I would say is that, not all immune diseases are necessarily improved with pregnancy. Some do get worse traditionally. So it's not necessarily like a universal immune downregulator. So that number one, maybe that might be it. But then number two is there's a lot of hormonal changes as well with pregnancy. And so just the increase in hormones can increase your von Willebrand factor levels and output. And so if you've just got more VWF circulating around, whatever ADAM-TS13 you had might be getting bound up at a higher rate, and that can drop your activity level as well. So I think there's it's multifaceted as to why pregnancy is a trigger. Yeah. All right. So I think that's the time. I'm getting the signal from Claire. But, save your questions, email them, or just come find, one of us afterwards and we can for sure talk more. Yeah.